if you want to try sharing your screen, see if everything's working, just test it out.
Please encosta a porta e já fala para frente. Precisa fechar, só encosta. Valeu.
Deixa o microfone ligado.
Pode deixar. Uhum. All right, let's get started.
Hello, everybody. Thank you for the invite. We will begin our section here, and I will share my screen. So today's issue is using DAGs to identify confounders and plan causal analysis in observational data, in observational studies. So I'm Marcos Campos. I'm a physician in Brazil and a Gemini collaborator at Duke University. So this class will focus in examples, and will be the main part of that class. But we will talk about some theoretical aspects before the examples. So let's do it. If you want any doubts, please let me know. You can share during the presentation. No problem for this. I don't know if I will see the chat during the presentation, but you can talk if you want. Our goal is to use DAGs to plan and justify causal analysis from observational health data. And so what is a causal question? Usually during our studies, especially in observational studies, we have very present in health research causal questions, but usually study associations, but we know that only association don't explain all the causal question. We need more than simplify association. And the DAG, that means direct acyclic graphs, give us a clear language to encode assumptions about how variable relate each other and how to decide which covariates to adjust for and explain better than an association. We know the correlation is not the causation. This is a fun example when a plot showing an increase ice cream sales with increase shark attacks. There is an association, but there is a non-logical explanation here. Obviously, maybe because of the weather, the summer, during this period, I have the increase of both. But this is a confounder. The summer can explain the both, despite the two variables are associated. So the confounder can explain two causal paths. This is example when I have smoking causing cancer, lung cancer, for example, but I have confounders, for example, age, for example, other exposures that they can explain the both. One association with lung cancer, for example, is drink coffee. But we know there are not a biological sense explained by the drinking coffee can cause lung cancer. But we know there is an association between drinking coffee and the smoking can cause cancer. This is an example of confounders, and we need to understand what it means in our analysis. The age usually is an important confounder in a health research because age can imply different exposures and different outcomes in health research, and we need to understand this and other kind of confounders. So, summarizing, correlation does not imply causation, and confounding can cause also both exposure and outcomes. And it can distort the association and implies in a bias. And here again, this is the danger of just know one side of the history, and correlation is not causation. So to begin our analysis, we needed to set what is the variable of exposure and what is the variable that we call outcomes. And we need to start for this and precise the estimation, the estimative between any authors. It's like, is this a risk factor? Is this a protective factor or a neutral effect? And we need to know what is your population or the time of the study and what kind of scale we use, risk difference, risk ratio, odds ratio, hazard ratio, and how it connects each other. And so we need to ask, what is the total effect of setting treatment, like exposure, and the outcome, for example, mortality, within a specific population and over a specific time? And what can implies also in the outcome? What variables can interfere also between exposure and the outcome? This will clarify and will determine which variables belong in your DAG and which you should or not should adjust for. And we have different associations and different settings of that kind of variable. The first one is the confounder. As we said, a confounder is a pre-exposure variable that causes both exposure and the outcomes. And we need to adjust it for confounders. There is an example. We know the age influences the probability of receiving treatment, and we have our exposure is a treatment, and the mortality is the outcomes. And age can affect the treatment and affect the mortality. We know elderly people has more mortality, and elderly people can take less treatment. Just an example. Another example is socioeconomic status can influence use of alcohol as exposure and hypertension as outcomes. Socioeconomic status can influence both at the same time. So if we see here, we have that we call a door, a back door. we have a pathway that is a bias, and we need to block this door, close the door, and we'll explain better our hypothesis, just letting the treatment, just let the exposure, just let the outcome without the confounders. And because of this, we need to adjust. So the collider is another example. And here we can see the difference between the confounders. A collider is a variable that is common effect of two or more cases. For example, we have hospitalization as a collider, and it depends of the treatment, the exposure, and the outcome, for example, the mortality. So hospitalization is not the cause of the treatment. Actually, the treatment will cause hospitalization. And the hospitalization, we'll have more hospitalization between the severe cases. And it doesn't imply the outcome. So this is not a door. They are actually, it's a closed path. And we don't need adjust for because this is not implication in a bias analysis. However, if I adjust for the collider, I can imply in a biases because I will see in this example just the severe cases and not all the cases that I want to study. I don't know if I was clear, but I will give another example of collider and will be more clarified. So this is not a cause of both exposure and outcome, and because we call the collider. And the mediator it's a variable that is set on the causal pathway. For example, here I have as exposure sodium intake, eat more sodium. That sodium, my hypothesis is that intake sodium, I will have more stroke. But we know how is the pathway to cause stroke. I eat more sodium, and I will have more high blood pressure, and high blood pressure will give me a stroke. So blood pressure is a mediator. This is on the way and not another causal because I depend fast for the blood pressure. And here it's not necessary adjust for because this is between the two variables. And however, if I adjust for this because I didn't change my way, and this is not a door, and I don't need to controlling for this. So sometimes I need to adjust for mediator, but it's not common. And in most of the time, I don't need to adjust for this. This is just on the pathway, but don't change my analysis. This is an example from a paper about the orthopedic surgery. They set clear examples of confounders, mediators, and colliders. And here, an example about orthopedic surgery. I have the exposure. This hypothesis is implanting type. And the outcome is the risk of revision of the surgery. And the confounder is the age at surgery. We know the age of surgery can imply the implant type, which implant I will put in my patient. But the age at surgery alone can explain the risk of a revision. Elderly patients can have more risk of revision than younger patients. So this is a confounder because they cause the both at the same time. As a mediator, this is another example. My hypothesis frailty can let more readmissions in the orthopedic surgery. And as a mediator, I have the postoperative complications. So frailty will imply in more complications, and complications will imply in readmissions. This is not cause frailty. It's not the complication that will cause frailty, but this is between the two, the exposure and the outcomes. In the collider, my exposure will be education level, and my collider is selection bias for an study, for example. So education level, sorry, the exposure is the education level, and the outcome is surgical outcome, for example, mortality. So I have a clear path between education level and the surgical outcome, surgical mortality, for example. But I can cause also the selection bias because if I have a high education patient, probably they will adhere more the hospital services, and I will select more for the studies. And this is a cause of the collider. In the surgical outcomes, the patients who survive will be better selected for the studies. And this is a collider also. So the exposure calls the outcome, and the outcome calls the collider. It's like a collider is event, sometimes happens after the outcome. And because of this, I don't need to adjust in your analysis. So what is DAG actually? DAG, as I said, direct acyclic graph, is a qualitative map or a graph of our causal assumptions. We have nodes, is the circles that we call variables, measured or not. Sometimes we have unobserved variables. Arrows are direct causal effects. If you see you have an arrow and you have a direction, which implies in which one. And this is a cycle because I don't have no feedback. I don't have feedback loops, and the variable don't have connection with themselves. If feedback exists, index over time. DEX come from the domain knowledge, not from the data mining. This is important because it's not requiring only the data set to draw the DAG, because I need the knowledge. I need to see on the literature what they say about the connections between the variables. This is not from our own data, but it's more about our analysis and our study to know the connections. So because of this, we need to study very deep or issues or do a good literature review to understand the connection between the variables. So we use DAGs to decide which covariates to adjust for, avoiding bias, confounding, selection, and make assumptions explicitly. So we can do the DAG to create a theoretical model that explain our study. This is explain. This is a DAG, sorry. And the hypothesis having diabetes can cause more toxicity by chemotherapy. This is a hypothesis. So we have all that variable on the data set, and we need to know which of the variable I need to do adjust for our analysis. For example, we have the variable. It's the obesity, but the obesity is causing diabetes, and diabetes go to toxicity. So I don't need to adjust the obesity here because they are not causing directly the problem, the outcome. So I have radiotherapy, chemotherapy, all this will imply toxicity. But it's not the fact that I have the radiotherapy that will not cause diabetes. directly. I don't have a connection pathway here. But I know if I have diabetes, I have more radiosensitive, and the radiosensitive cause the outcome toxicity. And I have old age. I know the old age can cause diabetes, and the old age can cause radiosensitive. Despite they have diabetes, I can have radiosensitive just because the old age. In here, I have a clear example of confounded because they are causing both, and radiosensitive will imply in the outcomes. So when I draw that, I can see clearly which one is confounder and which one is a mediator or collider. So a question for you, which of this variable I can call mediator? Can someone tell me? If you understand.
Maybe radio
Radiosensitivity?
sensitivity.
Exactly. Because the radio sensitivity is in the middle way. So I have diabetes, leads radiosensitive, and leading the toxicity. So this is just mediating. This is just on the middle of the way, not imply radiosensitive don't cause diabetes, but diabetes cause radiosensitive, and radiosensitive cause toxicity. So this is a mediator. And the OGH is different. They are causing both. And because of this, in this example, I just need to adjust old age. How to adjust? So the adjustment depends of your analysis plan, and sometimes you can use the regression, logistic regression. You can use the propensity score. You can use I don't know what a kind of analysis just to adjust for this. So DAG is it's a draw. Yeah, it's simple that DAG is a graphic that I explain all that connections between the variables and explain theoretically my hypothesis. Another example, as I said, I will have uh, a lot of example in how to perform in different softwares. So this is an example about alcohol use in pregnancy leading to low birth weight. This is a hypothesis based on the observation, based on the literature knowledge, and I wanted to try to answer this using the DAG. So my exposure is alcohol, leading to low birth weight as an outcome. And the confounders will plausibly common causes of alcohol use and low birth weight at the same time, based on my study in my lectures on literature. So I ask you, which kind of confounders, based in your knowledge, we know cause alcohol and low birth weight? Can someone explain me? What do
Yes.
you know cause alcohol and can explain also low birth weight?
Prematurity?
Yeah, this is a very interesting variable, prematurity. But I will answer. This is a mediator because alcohol can cause prematurity And the child who born premature in preterm birth will have more low birth weight. And so prematurity is in the middle of the pathway, not the cause. It's not the child who born preterm will cause the alcohol use during pregnancy by the mother. Do you understand? They are not causing the alcohol.
Yes.
Yeah. I will give you an example. Socioeconomic status. So if the mother has a low socioeconomic status, based on literature, they have more use of alcohol during the pregnancy. We know that. But also mothers who are from a low socioeconomic status has more chance to have a baby with low birth weight because of any factors, but we know that based on the literature. Or for example, schooling, I don't know the name. Yeah. The scholarity years of study will implies in has more alcohol intake, and it also implies to have low birth weight. Or for example, smoking. If I smoking, I have an association with alcohol. We know that people who smoking usually take more alcohol or another kind of drugs, but only the smoke can explain also the low birth weight. So based on literature, we selected that confounders. Smoking, socioeconomic conditions, income, schooling, and prenatal access. This is very interesting because the woman who don't do a good prenatal can have more alcohol intake and can have more low birth weight in a separate way, but they are causing the two at the same time. And the mediator, as Bruna said, preterm, it sits on the path in the middle of the way. So I have alcohol leads to preterm birth, and preterm birth will lead to low birth weight because it's a small baby and has a low birth weight. So just avoiding conditions, for example, just the patient hospitalized, the patient tested, the patient recorded, because that don't imply anything here. This is theoretical model and based in the, of course, in what data I have, but that conditions here doesn't matter. So we will see that example in the DAGT. I will show you, and after this we will see on R. So let's see on DAGT. What is DAGT? DAGT is a website. We can see on the Google. We can download the app, but we can use it online. And so this is the DAGT. We use to draw and analyze causal diagrams, the DAG, and we can launch it here online. So they begin in a very simple draw, and we can give it more complexity. So I will just begin a new model, okay? If I just click here, they will we will insert a name of a variable. So our X for sure is alcohol. This is our first variable, and I can call here what kind of variable I'm treating. This is the X for sure. So I can click again, and we will see our outcome is low birth weight. And this is our outcome. So I need to connect alcohol to low birth weight. Okay, this is our hypothesis. But we know a lot of variable can imply the same at the same time. So, for example, prenatal access. as you said, prenatal excess can cause alcohol, and prenatal excess can cause, sorry. Okay, if you see, when I set one variable here, causing the both, they change the color for red, and we can see this is a biasing paths, and they explain here biasing paths are open because I have a confounder here. So I have another one is smoking. Smoking also causes alcohol. This is just clicking one in the alter, and I can do the connection. It's very easy to do. So smoking is another a condition in another confounders, and we saw the preterm birth. We know alcohol causes preterm birth, and preterm birth causes low birth weight. So here on that example, I can see preterm birth. It's not to change the color for red because this is a mediator, and I don't need edge juice for. This is just an example, and we can see on the right side the adjustment recommended. So they always will say minimal sufficient adjustment set to estimating for the total effect of your exposure alcohol on outcome, low birth weight. So they select the variables that I need to do adjust. Prenatal excess, smoking are the minimal adjust to in your analysis. So if you see the preterm birth is not implied here, so I don't need to adjust for this. Okay, this is an example. If you see here down, I have all the comments, and I can copy this and repeat that graphic again. I can save this. I can export as a image, a figure, and using on my paper. I can change the color, the shape of the boxes. I can remove the color. It's more seriously graph. So I can change this, the format. I like it because of this. I have that control. And it's okay to use this on the paper. We have a lot of paper using graphics on the diagram. Now we'll see the same analysis using R. Okay. In R, we have different forms to perform the same analysis, and this is one. I will show in a few moments another form. And here we have a package called Daggery and ggdag that we use it for do the draws. Here the assumptions is what we said. I need to set what is the exposure and what is the outcomes. And here I typed alcohol causes low birth weight, alcohol it's causing preterm, preterm is causing low birth weight, smoke is causing alcohol, smoke is causing low birth weight, SES is socioeconomic status leading to alcohol, socioeconomic status leading to low birth weight, schooling causes alcohol. So I set this, again, based on literature, and I need to do this. I will share with you the script. So I run it. And I set what is your minimal adjusted for this. And this is a logistic regression that I use it for controlling my analysis. And here I adjusted for between alcohol and low birth weight. I adjusted for smoking, socioeconomic status, income, years of study, and prenatal care. So this is, they don't show the graph, but they can select the variables based in your specification and adjust and give yours or the final results. I don't think this is very intuitive, and I do a table more easily to see. So summarizing, they do automatic selection of the variables based on what I said. So this is our final table. The effect of maternal alcohol use on low birth weight. So I have the unadjusted analysis showing the odds ratio, and the adjusted analysis considering all the variables that the DAG said that I need to do the adjustment. So this is very interesting, can give us a more complexity analysis and explain the causal pathway. This is one form. So continue the presentation. The another example is smoking can lead to cardiac arrest. We know there is a connection between the both. And our exposure is smoking, your outcome is cardiac arrest. And we might assume that smoking causes change in cholesterol, and the cholesterol will cause cardiac arrest. So here the cholesterol is a mediator, because it's not the high cholesterol is causing smoking, but the smoking is causing cholesterol, and cholesterol is causing the cardiac arrest. So see the example in R. I will show another form to perform the DAG using the ggDAG package and the ggplot2 package. Just open the package. Okay, this is an example how we began to draw. We have two variables. This is just a draw. And if I use the function dagphi, connecting the variable y to variable x, I have the connection between the both. And I can do the arrow have both sense, both directions. And this is how I can insert a mediator, a variable on the middle. So let's go to our example. I will use the same function that I showed before. And we know that the connection is, I have the cardiac arrest, the smoking, the cholesterol. We know that unhealthy lifestyles can imply also in cardiac arrest, and can imply in smoking, and the weight also can imply in both. So here I changed the way I type the name of the variables. Here I can specify which one is latent variable, which one the exposure, and which one is outcome. So we have the exposure is smoking, outcome cardiac arrest. In latent, I consider the unhealthy. What it means? The latent is an unobserved variable. Sometimes I don't have in my database. But I know that implies probably unhealthy is caused by a combination of different variables, like sedentarism, like drinking alcohol, like I don't know, but morbidities, disease. So I have a pool of variables that can explain the unhealth. So because of this is a latent variable. But here in our theoretical model, we can use and we need to use to understand better the connection between the variables. So this is our DAG on R. So this is our exposure, smoking leading to cholesterol, and cholesterol leading to cardiac arrest. But we know unhealthy style can imply in smoking, can imply in high weight, and the weight can imply cholesterol, and cholesterol cardiac arrest. So I have another way here. I have a door. Another door can explain the connection, and then can explain the cardiac arrest. And we need to control this. So if I use the ggdag paths function, I can see explain the potential paths that explain our model. So I have smoking, cause cholesterol, and cause cardiac arrest. But I have also smoking, unhealthy styles, weight, cholesterol, and cardiac arrest. So I have two ways to come to cardiac arrest. And using the ggdag adjustment set, they will say for us which of that variable we can adjust to control the bias way, because we don't want the bias way. So here in our example, the minimal adjust is the variable weight. What they are saying? In our analysis, when I will see the association between smoking and the cardiac arrest, I need to minimally adjust for the weight. Because in your theoretical model, this is a bias in your analysis. So the DAG helps us to determine which of all that variables I need to adjust. If I adjust cholesterol, maybe my analysis will be wrong. If I adjust to unhealthy lifestyle, maybe my analysis will be wrong. So just adjusting weight, I needed to justify this is the minimum I adjust, and my analysis will be right, probably. So we have limitations about DAGs. Of course, it depends on prior knowledge. Sometimes we omission some variables that are very important, and the adjustment set will be wrong. For example, sometimes we have a limitation of the knowledge, especially related to genetic issues, because we have the generic have different implies on health, but we don't have that information in your database. And sometimes our theoretical model is not complete, but based in what I have and based in the literature knowledge. So sometimes we know the health is a very complexity in settings, but we need to draw on the DAG the more complex explanations, but of course, be parsimonious. Be parsimonious in aspect of don't put a lot of variables that can complicate, and it's difficult to explain after to discuss this, but insert the best variables that could explain your model. For example, we saw the alcohol use in pregnancy and low birth weight. Smoking is a good option to put here, but some detailed variables could give you a complexity that is difficult to report that after. So we have a lot of variables that we could set there, but in the reality is difficult to report this. So because of this, different DAGs can imply different results. And if I do a DAG based on my knowledge, and João do another DAG, maybe I have different results. Depend of the connections that we set in he said. Because of this, we need a clear phi pathway, a clear phi draw, because we need to do a reproductive DAG, and that other researchers could reproductive. Many causal assumptions can be verified with our observational data alone. In no magnitude of functional forms, the DAGs tell you what to adjust, not how to model. What kind of analysis I will do to adjust. They just said adjust for this, but not how. And how to mitigate the limitations, we have some options, but the main I consider is that prefer minimal and parsimonious set, check positivity, overlap, and respecify if need. So think about what kind of variable you will set in your DAG, because it will have an implication. Discuss with your mentor which matter to put in your model, because it will have some implies, and I need to be ready to how to adjust this. So sometimes we have a very complexity DAGs like this with a lot of variables, and sometimes this is explained to report after how to consider all that interactions and connectivities. But the DAG could guide the studies design in the data collection, clarify the estimation, exposure, and outcomes, and prioritize which variable to measure. Select a proper adjustment and reduce bias. Identify the minimal sufficient set to adjust, and avoid adjusting mediators and colliders that we don't need to adjust. In the anticipative selection bias. If we do a DAG before our data collection, for example, I can see which kind of variable I need to collect on my study. If I primarily collect data, I can visualize it in a DAG which variable is important or important to collect during my collection phase. So DAG help us to improve the transparency and the reproducibility on science, make assumptions explicit. I can do a draw, and another person just reading the draw, the graph, we will understand what is my hypothesis, what I consider on my setting, and plan my sensitivity analysis. I read in a book that phrase I like very much. We often talk about confounders, but really we should talk about confounding. This is true because the confounding happens in different ways, and the DAG helps us to understand the confounders, but also the confounding, because it is about the pathway more than any particular node or variable alone. So this is my references, and I have the supplementary materials, tutorial. I put everything here, and I can share the script on R. And I during the presentation, I have the DAG link, and that is all. Thank you so much for your time.
Thank you, Marcos. Thank you very much. This was very well explained. Thank you. Very detailed. Thank you for the time you put on the presentation. Let's make sure that these slides are linked in the toolbox. Okay. So folks can read and reuse as needed. I would also want to ask someone to volunteer to reproduce Marcos' codes so that we can move towards having a template of using Dagify for the work. I've seen a lot of people, especially folks coming from the biostats program at KCMC, that choose variable based on p-values at the unadjusted phase, at the bivariable phase. And I want us to push to use this approach to choose variables. So we don't have time today. We probably need to do another version. So if someone can be responsible to replicate Marcus R codes and make sure that they are running, that they are consistent, that they are templatized, then we should probably have another session where we go through the codes in more detail. And we go a little bit more careful on how you make decisions. So the last example Marcus showed where Dagify chose the pathways, the idea is that in the model, you would model those both pathways to see how they would lead to the answer. And the difference, the reason why you would model both pathways is because they have different confounding. One of the pathways, for instance, had smoking to cholesterol to then the outcome, and then smoking to weight and then to the outcome. And one would argue you should have cholesterol in the model because it's an important confounding. But what the DAG is showing is that it's not a confounding as much as it's on the causal pathway. So maybe if you adjust for weight, you are already adjusting for the impact of cholesterol, while cholesterol is in the causal pipeline. So if you add that as a confounder, then you're biasing the weight variable, and you're biasing the association of smoking with the outcome because it's in the causal pathway. So that kind of reflection needs to go into defining the predictors, because a lot of times we add predictors that are too close to each other, confound each other, and then end up creating models that are giving us adjusted results, but it's very hard to interpret them in the end based on all of the confounding that is being added. We need to do this process more consistently. It's harder to do it this way because you rely more on content expertise. And as methodologists, we don't like to do that very much because we have to go back to the content knowledge, have a back and forth. But I think it's very important to do it, to be able to build models that are more consistent. Now, all of this, what Marcus shows, is dependent on creating appropriate DAGs in the beginning. Like the system is not going to tell you which DAG is the important one. You have to build it, and you have to build it the most theoretically possible. Every time you guys write variables were chosen based on theory, that's what you're trying to say. Okay? All right. Marcos, there were some questions on the chat. I wasn't able to see them. I just saw them coming up. So I would say folks that had questions and want to share them with Marcos, please feel free to engage. I don't think we're going to have time to cover all of them here.
Oh, okay, I saw the question of the William and the Edwin. Oh, just the Edwin.
Yeah. So
yeah.
do you wanna give a quick answer, Marcos? Or I think we're not gonna have time. We're 4 minutes out.
Yeah.
What do we have up for next week, Leticia?
We have the poster presentations for the Global Mental Health Conference.
Okay, great. All right. We'll keep those questions, Edwin. We'll probably have to do another session. So thank you, Marcos, again. Appreciate it.
Thank you so much.
All right. Thanks, folks. See you again next week. Bye.